First, I would like to thank the organizing committee for a kind invitation to join this wonderful meeting. And my talk will be pertaining to the myths in infection prevention. The objective of my talk over the next 20 to 25 minutes or so would include, first, I would like to share with you the definition of the myths and also the example of the myths in infection prevention and also the solution to these myths. I would like to start first by quoting what Dr. William Schaffner has been written in Infection Control Journal in 1980. At that time, the journal has transformed into Infection Control and Hospital Epidemiology, a very famous infection control journal. What he described about the myths in infection control in 1980, he described it in two ways. First, the myths can be described as a belief given uncritical acceptance by a group, especially in support of traditional practices, or a notion we hold to be true but without factual basis. The problem is that the widespread belief in these myths really obstruct the recognition of reality, and while the doctor and the nurse keep doing this myth, it will obstruct the progression of infection control as well. So with that, in this session, I would like to give the example of some of the belief that we have in infection prevention. First is the hospital infection really save money. I would like the audience to vote. And because this is a video taping session, I really think you can vote quietly with yourself. A, you agree with the sentence. B, you don't agree. This is probably the myth. And C, you strongly disagree. This is totally a myth. And D, you are not so sure about the hospital infection really save the money. With that in mind, the truth is that some nosocomial infections are really preventable. And by preventing them, it would really save a tremendous hospital stay, diagnostic costs, and intervention costs that in turn result in a large sum of money that would have been saved. The mystical aspect about these is whose money will be saved. For example, if you look at the third-party payer, their money will be certainly be saved. But in reality, infection control program will increase the hospital expenditure, and hospital administrator not only consider the direct cost of the program, but also consider the cost of the policy and procedure change. And now today, there are many other devices and intervention integrating in infection prevention activity as well. With that, Dr. Schaffner have defined the cost into three ways. First, the intervention or policy infection control that costs the hospital additional money. Second, infection control or policy that save money for the institution. And lastly, any policy that have the trivial impact on the hospital cost. This is what Dr. Schaffner has been described in 1980. The example of the policy that are associated with additional costs, including a lot of activity listed in here, while the policy that associated with reducing the hospital costs, including stop doing the routine culture of the student there for MRSA and stop doing routine environmental culture, etc. While there are a lot of policy at that time in 1980 that consider have a trivial impact on the cost as well. Now today, we are practicing advanced science in infection prevention. And when I in doubt and you are encountering the situation where the cost is also very high and the effect of the program or intervention is also very high. In this situation, we have a science called cost effectiveness analysis to help analyze the program, whether or not you should invest on the infection prevention to have a better outcome on the patient care or not. Likewise, during COVID, there are many beliefs that thought to be untrue, but has been widespread in the social for the prevention and transmission of COVID. For example, some people may say that if you drink alcohol, it will kill the COVID. And some people in the social saying that if you spray alcohol all over the body, it will help prevent the COVID. These are the example of the myths that when it's spread, it will obstruct the reality. And when you are doing so, it will certainly retarding or preventing the progress of infection control. The next question that I would like to obtain your thought is, should we really discontinue contact precaution for MRSA and VRE? A, you agree that you should adopt discontinuation of contact precaution for this pathogen? B, you think this may be a myth? C, strongly disagree, this is totally a myth. And D, you are not sure, this may not be a myth, but I'm not so sure about it. So you can quietly voting. The fact is that they are now accumulating data that start from the RCT in single center and in multiple countries. And now we have evidence in terms of meta-analysis suggesting the clear benefit of de-implementing or stop doing contact precaution for MRSA and VRE. But in my view, there are some mystical aspects of what people in the academic say limitation of the study, including the fact that these hypotheses and effect that you see may perhaps due to the lack of effectiveness or compliance with the contact precaution in your institution, or perhaps in the study that performed the study has such a low transmission rate of endemic infection already, so it's really have no impact on contact precaution in that way. It is also very important to note that the concept come from the country that clearly implement the horizontal approach for infection prevention, including increasing the compliance with the hand hygiene, using correctidine bedding in all inpatients, particularly in the United States, and also using of the care bundle that by itself have a tremendous impact on the reduction in the rate of MDRO pathogen as well. So the pragmatic approach, while we are really fine-tune the evidence for the implementing the contact precaution for MRSA and VRE, we really be cautious and use pragmatic approach, considering using still contact precaution for our high-risk setting like the ICU and for high-risk patients. If you consider using it, you have to have the policy to discontinue contact precaution and also use in a high-risk patient population. And these are the suggestions to compromise the evidence that occur in reality globally. Thus, widespread belief in the myth will obstruct recognition of reality. And in doing so, if you are practice the myth all the time, it will obstruct the progress of infection control. It is what Dr. William Shatner saying in 1980. And actually, there's now a science called the implementation science. The implementation science is an evidence-based. The implementation for a contradicted, unproven, and aspiring healthcare practices by stop doing ineffective medical practices, which should be a part of evidence-based medicine. It typically occurs many years. It takes many years to occur, and the example is the routine use of glove and gown for precaution. Such resistance to evidence will inflate healthcare costs, of course, and may distract doctor from what they should have done. For example, the time that they should spend for the patient care, rather than doing these unnecessary practices. There's a side called medical reversal. suggesting to implement things that we do in medical practice. And there is a quote from the newspaper at United States, the New York Times, suggesting that many practice that we perform, up to 1,000 practice, has not been supported by the study that has been published. And this is the country like United States is supposed to be very advanced inside, but people still really doing the way they do it for a long time. To be fair, the implementation also requires a lot of effort to implement it. For example, if you do a lot of study from observational study to randomized control trial to implement it, the same pathway would have required to implement the things that you perform in implementing the science in infection prevention as well. The next part, I would like to share with you the example of how to implement things, and this I would like to start with the surgical site infection. That from the global evidence, it suggests now that at least 55% of surgical site infection is preventable from the global data. But if you look at the evidence in the guideline, there are at least a very strong recommendation to not performing these infections for surgical site infection, because we do it for a long time. It turned out to be a behavior. It's also very difficult to implement it. And these include during pre-operative period. Do not remove patient hair if absolutely necessary. Use the clipper. And during operative period, using the laminar airflow should not be now performed in any new OR that has been built. And also in the post-op period, do not use prolonged surgical antibiotic prophylaxis in the post-operative period. And these are a strong recommendation not to do or be implemented in the science of surgical site infection prevention. Generally, there are a lot of barriers to obstruct the way we implement these practice, including the surgeon might have done it for a long time. It is very difficult to implement it, and there are very skepticism concerning about the new study result, and there are a new training necessary to implement the new measure, as well as the impact on the cost if you would like to introduce an alternative measure as well. I would like to start with during pre-operative period. Do not remove the patient hair. If absolutely necessary, use the clipper. And this has been a clear, strong recommendation, which has been supported by multiple evidence. This is an example of evidence, as you can see here, comparing many methods, including the clipper, the laser, the chemical depiction with the standard shaving. Each alternative method have a significant impact on the reduction of the rate of surgical site infection comparing to the shaving, and this has been consistent in multiple studies and multiple RCT, as has been shown in here. So the laser should not be routinely performed in the healthcare epidemiology. But general problem is that doctors typically don't really follow this thing and recommendation, and how to overcome this barrier also require a lot of effort, including the consensus in the IPC committee, the information for healthcare worker and the patient. You really need to reorganize easy access to the clipper and organize the hair removal procedure, and then you require audits to changing the surgeon behavior. The second item is don't use laminar airflow. This has been proposed in the guideline that no more laminar airflow in the risk surgery like arthropathies and other surgery that has been previously thought to be necessary. This has been supported by many systematic review and meta-analysis suggesting that there's no clear benefit of laminar airflow compared with conventional airflow in preventing surgical site infection during hip and knee arthroplasty and abdominal surgery. And thus, laminar airflow is not evidence-based medicine to prevent surgical site infection anymore and should not be installed in the operating room. There are some evidence also consistent across many published literature suggest the same thing, that there's no clear benefit of the laminar airflow in compared with the conventional airflow in the theater. Therefore, it is very important for us to focus on IPC, which have a very good evidence to support instead of implementing this unnecessary and not proven benefit on the intervention to prevent SSI. Believe it or not, barrier for stop this thing is also a lot, including the belief in the evidence. Some people don't believe in the evidence. The local health authority in some countries still require laminar airflow, and there are some national guidelines require laminar airflow. And of course, the industry is interested to sell laminar airflow ventilation system as well. The way to overcome the use of laminar airflow also require an extensive effort, including the consensus in the IPC committee, interaction between the local health authorities, and you have to develop a national consensus with ongoing search for optimal ventilation system as well. The last item is do not prolong surgical antibiotic prophylaxis, and this has been recommended as a strong recommendation with a fair amount of evidence to do the practice as well. The rationale behind it is also very clear, that if you have a surgery and you stop antibiotic quickly, it will restore the gut microbiome, and it will be helpful to suppress the pathologic biome. If you do the opposite things, you will see the opposite outcome, including if you do the prolonged antibiotic prophylaxis, it will suppress the microbiome, and in turn, the pathologic biome will increase, and you have a clear chance of getting the infection, like surgical site infection. It's also very clear in multi-center, multinational study that look at the different time frame of antibiotic prophylaxis implementation for the outcome like surgical site infection, acute kidney injury, and the occurrence of C. difficile. The study finding is quite consistent that there is no clear benefit of prolonged antibiotic, while the prolonged antibiotic, particularly more than 24 hours, has been clearly associated with the adverse outcome, include acute kidney injury and the occurrence of Clostridium difficile. Clearly, barrier for stop prolonged surgical antibiotic prophylaxis has been quite clear, and I'm sure that if you are involved in the field, this is the issue that you are fighting with the surgeon for all your career. And the barrier, including the surgeon believe that if they stop antibiotic early, it will not save for their patients. They are not believing in the evidence. They are not believing that this evidence do harm to the patient in reality as well. So the way to overcome such barrier is to use a multiple approach, including the multidisciplinary antibiotic management team. You really need audit and feedback to the surgeons. You really need electronic stop order, and you really come up with the education about the side effects of prolonged antibiotic prophylaxis as well. In summary, in this session, I shared with you that in infection control, since 1980 or before 1980, we see many myths in infection prevention, and it will continue to happen. With the era of COVID, we also see many myths. And the implementation of myths of non-evidence-based IPC practice in medicine and in infection prevention is also very difficult, similar to the new intervention that you introduce, because it will require the similar effort to be implemented, and similar type of intervention and study has to be developed as well. Education about the correct IPC measure is usually not enough to implement the myths, and routine audit of IPC measure with appropriate feedback are useful to stop the use of this measure. And lastly, I think to completely eradicate this thing, we have to come up with the behavioral target innovation to help integrating into the healthcare epidemiology to have a successful demystification in a long term. With that, I would like to thank you, the audience, very much for your attention. ขอบคุณครับ